Okay, so let's start here with lid lumps or lid tumors. I have the first category, which is benign and pre-malignant tumors. I have something called papilloma, and this is related to what? Related to which virus? It is related to HPV virus, and I think I have mentioned some of these in the previous part or the previous branch, which is ocular surface disease. I mentioned this one, which is papovirus or HPV, which is one of the papoviruses. And I told you that I have two categories. I have more than one subtype. Number 6 and number 11 subtypes are related to this one, which is benign one, related to papilloma, and number 16, 18, they are related to the most aggressive one, which is squamous cell carcinoma or ocular surface squamous neoplasia, OSSN. I told you these, and I told you also about the chemotherapy or the treatment with the systemic cimetidine and also topical interferon alpha 2b. That is for the conjunctival one or the conjunctival disease or the ocular surface disease with this one. Also, you may have eyelid disease like that. You may have eyelid disease which may have two clinical types, like narrow-based or pedunculated one, or a broad-based or sessile one. Okay, so as you see, this is papilloma like that. What about the treatment of this one? What do you think? What do you think of the treatment? It is just shaving. Okay, so you just shave this lesion, and the treatment is by simple excision. Actually, if you yes, excision, yes.
Okay.
Okay. Look at this one. Look at this one here. You can see that you have raised epithelium, no more. Okay, it is just raised epithelium like that. This is the histopathology or the pathology of this one. Look at this. This one is narrow-based like that, and it is pedunculated lesion. Treatment usually involves simple excision, as I told you, but other options include cryotherapy or laser or chemical ablation may be employed. Here you have also basal cell papilloma, which is extremely uncommon in contrast to or in comparison to if it is compared with the squamous cell papilloma. So the most famous one is the squamous cell papilloma, but this one is common in elderly. They are derived from the basal cells. Actually, I have just one slide like that. If you compare between this and the other, here you can see that the hyperplasia is in the basal cell of the epithelium. It is not in the superficial or the squamous cell like the other. Compare between this and this. Here, look here and look here. Here, the hyperplasia is in the superficial layer, not in the basal layer. But look here, downward here in this slide, you will find what you will find that the hyperplasia is in the basal layer or the deep layer, not the superficial one. Also, you may have cutaneous horns like that. You may have cysts like that or epidermal cysts like that. Okay, and the lesion is pigmented and sessile. It is not pedunculated like that of the squamous papilloma. What about the xanthelasma? Then xanthelasma means that you have what? What do you think? You have fat? Yes, you have fat, but this is intracellular fat, unlike that of the calizium. Remember this one. What is the diagnosis of number 1 and number 2? And what the difference between them? The histologic difference or pathological difference between them?
That's granulomatous inflammation.
Yes, number 1 is granulomatous inflammation, which has a central core of lipid like that. Okay, this central core of lipid dissolved when stained with hematoxylin and iosine. Okay, so here it is dissolved fat like that. So this is an example of what? An example of chronic granulomatous inflammation of the meibomian gland, which is called calizium. Here, this one is an example of calizium, or this one is a slide of calizium. So when you see this central central dissolvement of fat, you mean that you have chalazion, and around this you see the granulomatous inflammation like that, or the aggregation of the cells in granuloma pattern. What do you think of this one? What is the main difference between them? Here, look at the fat dissolvement. It is intracellular. Okay, so here you can see that you have pale cells, or you have cells with dissolved fat, but you don't have dissolved fat as a core or as a central part like that. So the fat here is intracellular. The fat there was extracellular. Okay, this is the difference, the main difference between Untitled and also chalazion, because both of them are related to lipid disorders. Actually, this is more related to hyperlipidemia or dyslipidemia. It can occur in elderly, okay, but actually, or it is more common in elderly. But if you see this lesion in a young adult, you tell this young adult about what? You tell him to do lipid profile, because this may be related to hyperlipidemia or a problem with the lipid profile. What is the name of these cells? These cells had dissolved fat, so it has a name. These cells have names, okay, which is called foam cells. Okay, it is like foams, so it is called foam cells like that. Okay, these are all the slides of the Untitled, and this is the clinical appearance here. You can have multiple Untitled in the same patient, and here the treatment is what? Actually, number one, you must tell this patient to do a lipid profile in order to control his increased lipid level or hypercholesterolemia and so on. You treat this by simple excision, and actually I do this. I do for most of the cases of the Untitled, you do simple excision. But if it is extremely large, you will get a skin defect. So, for example, look here. If you imagine that we remove all these area of skin, so this will create a gap. Okay, this will affect the cosmetic appearance, and this is bad. What to do here? I can do microdissection. So I raise the skin as a flap, and under the skin, I remove the lesion, I remove the fat tissue, and then I resuture the skin again. Okay, this is called microdissection. Other modalities or methods, you can use chemical peeling with trichloroacetic acid. You may have laser ablation or cryo and so on. Okay. What about this one? What is the cell type?
Langerhans.
You know this cell? No, it is not Langerhans.
It's giant.
Also, it is a giant multinucleated cell, but it is not a Langerhans. It is called Teuton cells. Okay, and it is related. What is the association of this cell? It is associated with a very famous disease, which is called juvenile xanthogranuloma. Okay, so it is also a lipid disease, but it is called juvenile xanthogranuloma. So if you see something which is more aggressive than xanthelasma, and you suspect this one, just look at the slide here. If you see this kind of giant cells, then the diagnosis is juvenile xanthogranuloma. What about this one, keratoacanthoma? And what is the difference between keratoacanthoma and squamous cell carcinoma? Actually, if you see the keratoacanthoma like that, you may suspect squamous cell carcinoma. So clinically, it may be indistinguishable from squamous cell carcinoma, and this is extremely important, because here, if I see a case of keratoacanthoma, I can consider that it is squamous cell carcinoma until proved otherwise. So this is the main danger of this one. Because here the squamous cell carcinoma has a mortality rate, okay? But this one, keratoacanthoma, is benign or malignant or pre-malignant? What do you think? Benign or malignant or pre-malignant? What do you think?
Benign.
Yes, it is benign one, because here it will progress over 2 to 6 weeks, but actually it will regress and involute again. Okay, so here it is benign one. The danger of keratoacanthoma, it may be undiagnosed or underdiagnosed or missed squamous cell carcinoma. So here it is extremely important because of this, because it is resembling that. Look at this, may again be indistinguishable from an squamous cell carcinoma on histologic examination. And here, the characteristic appearance here, you can see that you have a cup. Look at this cup. Can you see this cup? This cup is what you have, a cup which is filled with keratin. Okay, but here the difference, the main difference between it and the squamous cell carcinoma is that this keratin has no cells, so you don't have parakeratosis. What do you mean by parakeratosis, hyperkeratosis, and dyskeratosis? What's the difference between them? Parakeratosis means that you have inside the melanin you have retained nucleus or retained nuclei. Okay, hyperkeratosis means that you have increased keratin. Dyskeratosis means that you have keratin in abnormal tissues or keratin in other in tissues other than the skin. Okay, you have abnormal keratinized surfaces. Like what? You have an example of this keratosis, which is what? Which is a bitospot. Can you remember bitospot, which is keratinization of the conjunctival surface or keratinization of the conjunctiva? This is called bitospot, and this is an example of this keratosis or dysplasia. Okay, so you have parakeratosis, you have hyperkeratosis, and you have this keratosis. Here, in this one, you have hyperkeratosis. You have a cup of epithelium which is filled with keratin, as you see here. And here you have a junction between what and what? Between the normal epithelium here, okay, and the abnormal epithelium here. And this is called the shoulder, which is the junction. Look here, you have a very important demarcation line between the abnormal epithelium here and the normal epithelium here. This one, like that, this is called the shoulder. Okay, so you have normal to the left of the slide, like that. And this is normal epithelium, and you have here abnormal epithelium, and the junction between them is called the shoulder. Look at this one. You have cup-shaped lesion. This is the cup, and it is filled with what? It is filled with keratin. That is for keratoacanthoma. What is the treatment of keratoacanthoma? Actually, it may be more aggressive in shape. It may have a cutaneous horn. But what is the treatment of this keratoacanthoma? What do you think?
Shaving.
Complete excision, not shaving, not just shaving. Complete excision with what? With safety margin. Why? Why, Dr. Eason? It is benign, but why do we do this aggressive treatment? Complete excision with safety margin. Because it may be... No, because it may be misdiagnosed as keratoacanthoma, and it is squamous cell carcinoma. So we treat this as if we are treating squamous cell carcinoma. Although it is benign, but we treat this as if it is squamous cell carcinoma. So every case of keratoacanthoma is squamous cell carcinoma, okay? And we can treat this squamous, this keratoacanthoma like squamous cell carcinoma. Here in nevi, I have acquired nevi, which are junctional or dermal or compound nevi. And here, this is a very easy way to remember this one. This is called junctional because here you have the melanocytes, or you have the pigmentation between at the junction between the dermis and the epidermis. And here it is very flat like that, okay? Look at this, it is flat and pigmented. Look at this one. This is called compound. You have at the junction and you have below the junction. So you have at the dermis and you have at the junction. This is called what? This is called compound nevus. Okay, and here you have it pigmented, but it is not flat, it is raised and pigmented. Okay, and here this one, it is just related to the dermis, so it is called what? It is called dermal one. So you have junctional, you have compound, and you have dermal. Which is more pigmented? Actually, this one and this one. So this one is pigmented but flat, this one is pigmented and raised, and this one is raised but it is not pigmented, because here the pigments are deep in the derms. Okay, which is more dangerous, or which is which has the highest risk of developing malignant melanoma? Which one? Number 1 or 2 or 3? This is 1, this is 2, this is 3.
1.
Yes, number 1, which is the junctional one. The junctional one, which is very flat like this. This has the highest risk for development of malignant melanoma. But all of them, actually, in order to reassure the patient, all of them have very low risk of developing malignant melanoma. Look at this. Overall, there is a low risk of transformation, which is slightly higher for the more superficial nevi. Okay, so the malignant transformation is not that common in these cases. This one is called what? This one is called congenital nevus, congenital melanocytic nevus. Here you have kissing nevus like the lips, because here you have in the upper lid and in the lower lid like that. This is called split or separate lesions in the upper and the lower lids, and this is called kissing nevi, like that. And here, actually, it has no significance, because also the malignant transformation isn't that high, except in what? Except in large lesions. Look at this one. It is a very large lesion with the systemic associations, and the malignant transformation here to malignant melanoma is as high as 15%. Treatment, if necessary, involves complete surgical excision, but here, in a case like that, you can just remove this lesion just for cosmetic appearance, not for the risk for development of malignant melanoma. Okay, that is for nevi. Let's talk about capillary hemangioma. Here, capillary hemangioma, what is the start time? What do you think? Actually, it is called strawberry nevus. Okay, what is, not at birth, shortly after birth. This is important. Dr. Eason, the child usually in these cases is born normal, okay, normal child. But shortly after birth, he will develop these collaterals or these blood vessels leading to this lesion, which can progress up to this appearance or even more. What the difference between this one, number 1, and this one, number 2? What the difference between them?
That's a kind.
Both of them are capillary hemangioma, actually. But what the difference between them?
It's skin also involved. The upper one.
Number 1 is superficial. You mean that number 1 is superficial, okay? But number 2 is deep, okay? Number 2 is very deep, and that's why it is purplish in color. But here it is red in color. Okay, so that is for number 1. Number 2, look at this one here. Also, there is sex predilection, because it is more common in girls 3 times as boys. So it is more common in girls. You have here female sex predilection present shortly after birth. Okay. Regarding the histopathology, you see vascular channels. I'll make it more obvious like that, using the high power or the higher magnification like that. These are the lobules or the vascular lobules like that. These are called the vascular lobules, but this is with the high magnifications. Look at these here. These are the high. These are also the vascular lobules here. This one and this one and this one and this one and this one, which has the arrows. The red arrows will are pointing at these lobules, or these lobules containing thin-walled capillaries. These capillaries are lined by single layer of endothelium, as you see.
And the lower picture differential diagnosis can be dacrocystocele.
Dacrocystocele?
It looks the same.
Dacrocystocele? No. Dacrocystocele is an inflammation of the lacrimal sac. Actually, Dr. Isan, let me tell you something which is extremely important. Here, the type of tissue must be mentioned in any specimen of pathology. Okay, so here the tissue is taken from the eyelid, but actually, if it was taken from the lacrimal sac, this must be mentioned in order not to mix between them. Okay, because here any pathologist must know the tissue from which we had the biopsy. Okay, if you don't mention this to the pathologist, he won't give you the result. Okay, so here, what is the type of the tissue here? It is the skin. Okay, and what the other type, like you said, dacrocystocele, it is from the lacrimal sac. So this is an important one to be mentioned, that the type of tissue must be mentioned before in order not to mix between them. Okay, the lesion may increase during crying, okay, during straining or crying and so on. Ptosis is frequent, but there may be an orbital, and there may be, orbital extension. Ptosis is frequent or somehow common. And what is the effect of ptosis in these cases, or in a case of capillary hemangioma like that? The patient will have amblyopia due to what? Which type of amblyopia? Let me make choices like that.
Deprivation of myopia.
Actually, this is a question in Provision book. And this is not that important book, but this question is present in Provision book, and deprivation was one of the choices, but actually the right answer is an isometropic one, because here this lesion will result in pressure on the eye leading to astigmatism. So these children will suffer from unilateral astigmatism, and this will result in an isometropic amblyopia, not sensory deprivation, because here you don't see that the lesion is significant enough to result in blocked pupil or closed pupil like that. Okay, so remember this one. This is somehow tricky, and if you don't know this for sure, you will pick sensory deprivation, which is easier to be deducted. Okay.
Yeah.
Okay, so here, what about the treatment? What about the most recent treatment of these cases of capillary hemangioma? Is it, yes, beta blocker, systemic or topical?
Topical.
Actually, topical may suffice. Okay, so the topical treatment right now is the topical beta blocker eye drops like timolol and so on is the treatment of choice. Just the application of drops over the lesion like that, this will result in a complete resolution or spontaneous improvement of these cases. Formerly, you have alternatives or modalities like systemic beta blockers, and also you may have intralesional corticosteroid injection, which was in the past it was the first line of treatment, but right now we use just topical beta blockers. What about actinic keratosis? You have keratoacanthoma and you have here actinic keratosis. What the difference between them? Look here at the pathology, or look here at the slide. Actually, you don't have the cup. You have hyperkeratosis like that, but you have what? Look here at this one. This is called what? This is called parakeratosis. What do you think? What do you mean by parakeratosis? Normally, you know that the keratin doesn't have any nuclei, but here retained nuclei in the keratin is called what? It is called parakeratosis. So you have hyperkeratosis, you have also parakeratosis, and you have acanthosis. What do you mean by acanthosis? It is thickened or increased this layer, which is called brachial cell layer, or the superficial layer, or the squamous layer. So in the epithelium, let me remind you with the epithelium of the skin, it is basal one, and after this basal one, you have wing cells like that, or polyhedral cells, and after this you have the squamous cells. So increased the thickness or increased the layers of this one, which is the squamous one, is called acanthosis, and this is also evident here in cases of actinic keratosis. Actually, let me make a choice. Actinic keratosis is benign or malignant or pre-malignant. What do you think?
Pre-malignant.
Yes, it is pre-malignant. Yes, of course, this is absolutely true. And this can predispose to what? Squamous cell carcinoma or basal cell carcinoma?
Squamous cell carcinoma.
Yes, squamous cell carcinoma, because here you have the problem is in the squamous layers. You have the hyperkeratosis, you have parakeratosis, you have also acanthosis, which is all related to the superficial layers. So this one is related to what? Related to actinic keratosis. Here, look at this one. Histologically, it shows parakeratosis and cellular atypia, but with no invasion. Here, you can see that you don't have invasion of the dermis. The problem is just limited to the epidermis like that. You don't see any invasion here. Here you have intact dermis, and here you have abnormal epidermis. So this is the main difference between the actinic keratosis and what? And the squamous cell carcinoma. Okay.
Sorry, Dr. Mesallamy, we couldn't hear correctly.
You couldn't hear me correctly? Can you hear me right now?
Yeah, there was lots of interruption because of internet connection.
Okay, but right now you can hear me.
Hello?
Okay.
Yeah, but broken.
Broken. Right now it is good.
Now it's good, yeah.
Okay, so let me repeat this one. Here, look at this one. You have here what? You have here parakeratosis. You have here hyperkeratosis, and you have here acanthosis. Okay, look at the dermis. The dermis is intact. Okay, so you have here the lesion, which is limited to what? Which is limited to the epidermis. If you have invasion, this will be converted into what? Into squamous cell carcinoma. This is the main difference. Do you understand this? Dr. Ethan left. Okay, my voice is clear for this one?
Yeah, I can hear you.
Okay, is this easy for you to differentiate between
Yes.
the actinic keratosis and squamous cell carcinoma? Actually, here you don't see you see no invasion here. So this one is just limited to the epidermis, and this one is called actinic keratosis.
Yes.
Okay. Okay, so let's talk about malignant lumps or malignant tumors. You have rare predisposing syndromes related to malignant tumors, and this one is called what? This one is called Zeroderma Pigmentosa. Actually, Dr. Isan, hi, I think the problem was in your connection.
Yes.
Okay, so here you have Zeroderma Pigmentosa like that, and this appearance is called bird-like features or bird-like face appearance, and it is autosomal recessive disease due to what? Due to failure of DNA. Okay, so this is failure of DNA repair. This is the mechanism of this disease, Zeroderma Pigmentosa. It is predisposed by ultraviolet rays, and actually it is related to basal cell squamous cell and malignant melanomas. This is extremely important. So Zeroderma pigmentosum is an important one. If you are sitting for the advanced exam, this one is important because you will find a question which is I think EMQ, not MCQ, EMQ, regarding Zeroderma pigmentosum. It is autosomal recessive. It is the mechanism is failure of DNA repair. It is predisposed by ultraviolet rays exposure, and the face is resembling the bird face. And here you have multiple basal cell carcinoma or squamous cell carcinoma. Here, can you see this one? You have this may be basal or squamous cell carcinoma. Also, you have malignant melanoma in relation to these diseases. Also, you have Gorlin-Goltz syndrome, which is autosomal dominant. There was a question also in advanced exam, which was about Gorlin-Goltz, but it is mentioned that it is accompanied by multiple basal cell carcinoma during the second decade of life, but it is autosomal recessive. So this one was false. This choice was false because this disease is just autosomal dominant. Also, it is related to some malignant disease, maybe related to medulloblastoma, breast carcinoma, and Hodgkin lymphoma. These are all related to Gorlin-Goltz syndrome. Here you have extremely too rare disorders or syndromes. You have Muir-Torrey syndrome. I want to remind you just with the name, okay? Muir-Torrey syndrome, it is related to skin malignancy, like basal cell carcinoma or multiple basal cell carcinomas, okay, and internal malignancies like colorectal cancers and so on. Okay, so it is related to cutaneous and internal malignancies. Also, it is autosomal dominant. Okay, this one, Bézik's syndrome, I want you to remember two issues. Just it is related to multiple basal cell carcinoma, and also it is X-linked dominant, because here we don't have many X-linked dominant diseases in our curriculum. In our actually, we don't have X-linked dominant diseases in general, not in our ophthalmology curriculum. In general, the X-linked dominant diseases are extremely rare, and all of these diseases are lethal to males. So the male will die. Okay, if the case is male, the male dies. Okay, this one is important one. What about the female? The female also will suffer from these diseases, which is related to, or this disease which is related to multiple malignancies or multiple skin malignancies and multiple skin changes. These are called all predisposing factors or predisposing syndromes. Here, let's talk about the basal cell carcinoma, which is the commonest one. 90% of lead malignancies in Caucasians. And actually here, what is the commonest location and what is the most dangerous location? What is the commonest location of basal cell carcinoma? I think this is easy.
Lower lid.
Yes, it is lower lid. What is the most dangerous location? Is it the lower lid?
Medial canthus.
Yes, it is the medial canthus. Okay, medial canthus. So here the most common location is the lower lid, and the second most common is the medial canthus, which is the most dangerous one. So here, this is number one, this is number two, but this is the most dangerous. This is number three, which is the upper lid, and this is number four, which is the lower canthus. So it is like a clockwise circle like that, from the lower lid up to the lateral canthus. Okay, the most dangerous one is what? It is the medial canthus, as you said. Risk factors include fair skin or white skin.
That's like the
What?
yes, I'm hearing you.
White skin?
Yeah, that's like a thyroid eye disease, also more common in the lower lid.
Excuse
in the
me,
inferior
which
rectus
disease?
muscle.
Which disease?
Thyroid, in Graves' disease.
Thyroid, yes, thyroid. We will mention thyroid eye disease or this thyroid orbitopathy. We'll mention this in a greater detail while we are talking about the orbit, okay? And this will be the, hopefully
Yes.
this will be the session after the next one. Okay, so the risk factors here include increasing age, white skin, sun exposure, ultraviolet rays exposure, and some cutaneous syndromes like Zeroderma Pigmentosa or Basal cell nevus syndrome. It is locally invasive, but very rarely metastasize. Okay, but here it is locally invasive, so the most dangerous complication of basal cell carcinoma is direct invasion to the orbit and so on. Okay, you have nodular type, and this nodular type can be subdivided into nodular, simple nodular, or nodular with ulceration, okay, which is called rodent ulcer. So you may have nodular type or nodular with ulcer like that. Okay, this is simple nodular one. This is small nodule, and this is larger one. Okay, what about this one? This is nodular with ulcer, but this ulcer is small and this ulcer is extremely large. Okay, and you have something called morphiform. What do you mean by morphiform? Here you don't have very sharp edges, or you don't have well-defined lesion. The sound is broken. Actually, I think that the problem is in your connection, Dr. Isam, or not. What do you think?
I don't know what are the other. You can hear? Okay, so it's my connection. Sorry.
Okay, so right now this one is called what? This one is called sclerosing type. What do you mean by sclerosing type? Sclerosing type is not well defined, or it is not defined to an area or a mass like that, but it is diffuse. Actually, it may resemble diffuse blepharitis, or it may diffuse chronic blepharitis. Any chronic eyelid inflammation may be resembling this one, and this is extremely dangerous because here this may be underdiagnosed or undiagnosed because of what? Because it is resembling. It is resembling what? It is resembling any chronic inflammation of the eyelid. This is the pathology of the basal cell carcinoma. Look here, is there epidermal invasion or not? Sorry, epidermal invasion or not? Look here, can you see these are beyond the epidermis? So you have involvement. Yes, there is invasion to the dermis, and actually it is blue or it is pink. It is blue, so it is basal 1. So here it is blue. This is number 1, and number 2 it is blue. Okay, so blue, this is the color of the basal cells, and it is blue, which is the commonest location, which is the lower eyelid. So remember this one. Here it is blue and blue. Okay, these are related to basal cell carcinoma. What about the treatment of basal cell carcinoma? Actually, the treatment of basal cell carcinoma is local excision achieved by Mohs micrographic technique. Do you know Mohs technique, which is accompanied by having frozen sections in order to frozen section, yes, control. A 3 to 4 millimeter margin is recommended. Actually, if you have a very wide safety margin, is it better or to do Mohs technique? What is the advantage of this and what is the advantage of this? The wide safety margin technique and the Mohs technique. What is the advantage of both of them?
The white one is more safer than
yes,
but if you want to protect
safer
the area,
and faster, safer and faster and easier. Okay.
Yeah.
What about Mohs?
Protect tissues
Yes,
as possible as.
Yes, here you minimize the skin loss. Okay,
Yeah.
So here in MOHS you minimize the skin loss, but it is actually it is harder because the recognition of the persistence or the whether there is persistent or whether there is malignant cells present in the section or not isn't that easy. Actually, the frozen sections are very tough to be seen. Okay, and the other issue is that it is time consuming. So here you may do excisional biopsy with safety margin, or you may do what you may do. You may do MOHS micrographic technique. Actually, this MOHS technique is especially for morphia form, which is a sclerosing type. Because of what? Because here you don't have sharp edge. You don't have you don't see the margins of the tumor. What do you think of having a skin defect? This is for the blepharoplasty after removal of tumor. If you have a skin defect which is 50%, what do you do? And what?
Semicircular flip?
Yes, semicircular tinsel flip. Yes, semicircular tinsel flip. What do you think of having more than 80%? Something like that.
Graft.
Maybe graft or maybe Hughes. You know Hughes, which is taking taking a tissue from the upper lid into the lower lid. This may be of choice, but if it is 50% or less, the tinsel flap may be sufficient for this purpose. What about the Quinosil carcinoma? Here in Oxford, it is mentioned from 2 to 5%, but in Kansky from 5 to 10%. So this is not that important. Here it is not the most common. The most common is basal cell carcinoma. This one is the second most common. It is much less common than that of the basal cell carcinoma, but has a much higher risk of malignant spread and mortality. So here it has a mortality rate. In basal cell carcinoma, actually, you can consider that it has no mortality rate. It preferentially affects the lower lid, again, like that of the basal cell carcinoma. Risk factors are the same: increasing age, white skin, some exposure, Zeroderma Pigmentosa. And here also it is common. However, this one, white skin, is a predisposing factor, but it may be common in Africans. Okay, so in Africans, if you want to choose some malignancy, it will be what? It will be squamous cell carcinoma, not basal cell, nor melanoma. Actually, it is squamous cell carcinoma, which may be more common. Also, it is related to HIV. Look at this one. Immunocompromised individuals such as those with AIDS or following renal transplantation are at increased risk. As are those with predisposing syndromes like Zeroderma Pigmentosum. As I told you, Zeroderma Pigmentosum is related to all malignancies like basal cell, squamous cell, and malignant melanoma. Okay, let's talk about the histopathology. Here it is pink and blue. So remember the basal cell carcinoma, which is blue and blue. Here it is pink and blue. Tumor cells have abundant eosinophilic, cytoplasmic, keratin pearls, and tonofilaments. Look at this one. Look at this one. Look at this one. Here, what about the dermis and the epidermis? Here you can see that the epidermis is also invaded like that. Okay, so there is invasion of the epidermis, and here the lesion isn't blue; it is just pink. And this means that you have malignant transformation. Also, I think in Kansky, here this one of the Kansky one. Here you have also parakeratosis. So you have acanthosis, parakeratosis, and this keratosis, like that of what? The same like that of the actinic keratosis, but with here you have right down here you have invasion to the dermis. Okay, so you have dermal invasion. This is the only difference between them regarding histology. Clinical features, you have here either nodular type or plaque type. Okay, so here this is nodular tumor with surface keratosis like that, and here this is nodular ulcerating like that of also like that of the basal cell carcinoma, and here you have cutaneous horn, which is plaque type or cutaneous horn 1. Okay, these are the main malignancies of, or the main oncology of the eyelid. Also, we will have sebaceous gland carcinoma, which will contain also foam cells, but we will, I mentioned this while I'm talking about the orbital tumors also, in order to differentiate between this and the lacrimal gland tumors and so on. Okay. Right now we will talk about disorders of the lashes. Actually, do you have any problem with the oncology of the eyelid right now?
Yes.
You still have problem? Okay.
It is still hard for me.
Excuse me?
In my practice, I couldn't I couldn't see this kind of patient, and so it is a little bit difficult for me.
It is difficult
For me.
Actually, it is difficult for all of the ophthalmologists, not just you, but here in the slides that I prepared, or the slides that you saw, you have any problem with these topics? If you have any problem with some specific topic, I can repeat this.
Thank you. You summarize easily. Thank you, teacher.
I have a question about actinic keratosis. Is it like in situ carcinoma?
Yes, it is like in situ carcinoma because it is just related to the epidermis, but with the same characters of malignancy, the same characters of malignancy, but related to just to the epidermis without invasion. And actually, this is written frankly in chemistry. It is written like in situ carcinoma or actinic keratosis, so they may be the same.
And cimetidine is H-COX blocker, and what's the rule in?
Actually, I don't know. I know this question. It may have immunomodulatory rule, so it may be related to immune therapy or immune therapy in treatment of cancer and so on. I had this question before, which is what is the role of cimetidine, which is not related to chemotherapy or something like that. I think it is immune therapy, not even chemotherapy, because if you look it up, you will find that cimetidine has immunomodulatory role.
Yes.
Okay. So let's talk right now about lashes disorders. Doctor, you need a summary for these diseases or not?
Not.
Okay, so okay. Actually, there is a very effective way for me in order to memorize them and in order to revise them to be prepared for any pathology slide. Is the very effective one is comparison between them. So I make the slides beside each other. Okay, so I make the slide of basal cell carcinoma together with that of squamous cell carcinoma, and that squamous cell carcinoma with the keratoacanthoma and actinic keratosis, and so on. The basal cell carcinoma is with that of basal cell papilloma or seborrheic keratosis. And here also I have squamous cell papilloma and so on. So this is extremely effective for me in order to remember the differences between them. This will help me. Remember the differences and remember the information related to them. Also, the xanthelasma in comparison to juvenile xanthogranuloma, in comparison to chalazion, and so on. Okay, so here let's talk about lashes disorders. Here you have lashes disorders. The most important topic is trichiasis. What do you mean by trichiasis here? Trichiasis means that you have mal-directed lashes of a number of more than 4 lashes. Actually, if it is less than 4, it is called rubbing lashes, and this is somehow we can't say that it is trichiasis, but this classification is old. So any mal-directed lashes, you can call it trichiasis, and this will be true. Okay, so either rubbing lashes or trichiasis will be true, but this is important. The importance of this classification is in the treatment, because in trichiasis you have multiple lashes which necessitates surgery. Okay, but in rubbing lashes, in the clinical variant, which is rubbing lashes, you have just 4 or a very small number of mal-directed lashes, so you can do electrolysis and so on. Okay, what is the cause or causes of trichiasis? What do you think? Here I have the commonest one, which is entropion. Okay, so all cases of entropion will have mal-directed lashes, because here you have this lid like that. Entropion means rolling inward. This is entropion, and here you'll notice that the direction of the lash will be towards the cornea like that, or towards the ocular surface. So here, in cases of entropion, or all cases of entropion, will be associated with trichiasis. So you have entropion with, trichiasis with entropion, or you have pure trichiasis. What are the causes of pure trichiasis? It is all the cicatrizing conjunctivitis, or all the scars, all the cicatrizing diseases, like what? Like ocular cicatricial pemphigoid, or Stevens-Johnson syndrome.
Trachoma?
Yes, trachoma, diphtheria, which are cicatrizing conjunctivitis also. Cases of trauma, like surgical trauma or chemical burns, these are all related to trichiasis. Also, in some cases like squamous or staphylococcal or ulcerative blepharitis, this may be related to also trichiasis and so on. Also, STI or hordeolum externum, which is at the root of the lash, this may be related also to trichiasis. So these are all cases of trichiasis, but here don't remember that you have all cases of entropion will suffer from trichiasis. Okay, what is the clinical picture? Here it is the ocular surface manifestations, which are 5 P's. I mentioned this before. Here you have stitching pain, and also because of the irritation. Okay, you have also photophobia, you have profuse lacrimation, you have poor vision, and the last one is not P, it is B, it is blepharospasm. Okay, these are the manifestations which are related to the ocular surface diseases because of the irritation between the eyelash and the ocular surface. I think this is easy. What are the complications, or what are the signs and the complications? Here for the signs, you have what? You have punctate erosions. Do you agree with me in that? You have punctate erosions because of the friction or the irritation between the eyelashes, the aberrant eyelashes, or the abnormal eyelashes, abnormally directed or mal-directed eyelashes, and the ocular surface. So you have punctate erosions which will stain well with fluorescein. You have also what? You may have corneal vascularization. Do you agree with me in that?
Yeah.
You have corneal ulceration, and this will result in the final stage in corneal opacification or corneal opacity. And if it is still persistent, this will result in keratinization of the ocular surface because of the irritation like that. So here, look at this one. Look at the causes. Here you have entropion, and this entropion resulted in mal-directed lashes like that. This resulted in trichiasis. Here, ocular cicatricial pemphigoid with scars. Can you see the conjunctivitis here, or the cicatrizing conjunctivitis? Also, Stevens-Johnson syndrome with the same cicatrizing conjunctivitis. And here you have the signs of mal-directed lashes. If they are more, this is called trichiasis. If they are less, this is called rubbing lashes. This is not important. Here you have inferior punctate epitheliopathy or punctate erosions, corneal ulceration, vascularization, and opacification, as I told you right now. Look at the fluorescein here. It is punctate erosions like that. I think this is easy. This is corneal ulcer. This is corneal vascularization and opacification, and so on. What is the treatment of rubbing lashes and treatment of trichiasis? At first, what is the treatment of rubbing lashes? Here you have temporary and permanent treatment. Temporary treatment is by epilation. Okay, you have epilation, but what are the indications of epilation? If you have untreated corneal ulcer and you want to treat the ulcer before you do the surgery or the procedure of removing these lashes, you just epilate until the cornea improves or the corneal ulcer improves. Okay, and what is the other indication? Here, if you are preparing some patient for surgery and this patient has the surgery right today, so you have to epilate the lashes before the surgery. So to prepare the patient for a major surgery or for any surgery like cataract surgery and so on, or to just epilate until you treat the corneal ulcer. What is the disadvantage of this simple epilation?
Recurrence.
Yes, 100% recurrence within 2 weeks. Within 2 weeks, you have the lashes which will be longer and sharper. Okay, so this one is very bad to be done, epilation. So it is a temporary treatment with indications. What about the permanent treatment? It is by electrolysis. Mainly, this is the most commonly used one, electrolysis. Here, what is the idea of electrolysis? Here it is a chemical reaction is created from tissues which contains water and sodium chloride. So this will result in NaOH or sodium hydroxide, and this will result in bubble formation. Can you see these bubbles? Bubble formation and removal of the eyelashes. The idea here is to be at the lash follicle. So the most important thing to be done well in this technique is to be directed or to be at the root of the lash. This is extremely important. If you are at any place else, this won't result in the desired effect, and this will be associated with recurrence. Actually, electrolysis may be also associated with recurrence, but if you do it correctly, the recurrence rate will be lower.
And it's under topical anesthesia.
Yes, under topical anesthesia. Actually, in some individuals require general anesthesia because it is extremely painful. Okay, I give subcutaneous xylocaine, okay, like local anesthesia, not topical, local anesthesia, together with topical anesthesia like sodium buccinate or tetracaine. So after this, I do this one, but some irritable individuals, because this is painful, when I counsel them about the pain, they prefer to have sedation or some kind of general anesthesia. Actually, sedation will be sufficient because it is not a major surgery. Okay, so you have epilation, you have electrolysis, you have cryo, but this will be associated with very bad cosmetic appearance, and laser and skin depigmentation and so on. Laser ablation, but you have for few scattered lashes, but you have to do it more than one time, like the laser ablation of the body hair. Okay, you have to do it more than one time, okay, by the dermatologists. But actually, we have this one, we have electrolysis, which is present, I think, in all hospitals, and this is of choice, at least for me.
What about the stichiosis? Can the stichiosis cause trichiosis?
I'll talk about the stichiosis, and yes, it can cause. I'll talk about it in a separate entity, because okay, they are two different entities. Actually, you have this trichiosis, which is abnormal extra row, and you have trichiosis, which is mal-directed lashes. They are different entities, and this trichiosis also may be symptomatic, and this will resemble that of trichiosis. But this is another another entity because the place is different, and I'll talk about it right now. For cases of trichosis, not rubbing lashes, not just rubbing lashes. If you have very multiple, or if you have multiple lashes, you have to do operations. And here for operations, you have to do what? You have to do transpositional flaps or Z+T. Here, this is the shape of the Z, okay? Imagine that you have the lashes here. Sorry. Imagine that you have the lashes here in this part. You just replace between this triangle and this triangle. So you create this Z or Z, and you transpose the two flaps, and you can bury these. So these lashes are buried. Okay, so you bury lashes under the skin and replace this one by this one. Replace this triangle, which is number 1, which contains the abnormal lashes or the aberrant lashes, and this one, which is number 2, which contains just the skin. If you just replace between them, you will create an ocular surface which has no aberrant lashes. If you want a video which is done on, it is not done on a patient, it is done on a sample, I can send you this one.
But can you bury the lashes under the skin?
Yes, simply yes.
No irritation, yeah?
No.
Oh, okay.
Okay, so what about the mucous membrane grafting? Here, look at this one. The problem is that the lash is directed towards the ocular surface. So if you open the gray line like that, and here fill this gap with, or fill this area with mucous membrane, look at this one here. This one is missed here. It was here. Okay, so here I imagine that I have here the anterior lamella and here the posterior lamella, and in between I have the gray line. In the gray line I put mucous membrane. This mucous membrane will result in what? Will result in will make the lash, which is still abnormal, but abnormally directed, but it will be away from the ocular surface. This is the ocular surface, for example. Okay, so this is called Van Bellingen operation if it is done in the upper lid. In the lower lid, you have the same technique, but here you open. You don't open in. Actually, you don't open in the gray line. You open in something called sulcus subtarsalis, which is at the conjunctival site, as you see. And it is 2 millimeters away from the lid margin, like that. Okay, so you open in the sulcus subtarsalis, and also you make this sulcus subtarsalis stuffed with a mucous membrane. So these are called mucous membrane grafting, and the purpose or the aim of these mucous membrane grafting is to make the mal-directed lashes away from the ocular surface. What about distichiasis? Here, distichiasis, Dr. Eason, is an extra row which is present in which location? What do you think here? It is in the white line. So it is related more to meibomian gland dysfunction. So here you have aberrant, not aberrant, you have extra row of lashes at the white line. So this is the normal lashes, or these are the normal lashes. This is the normal lash line, okay? And this is the abnormal lash line. So you have normal and abnormal lash lines. Okay, so this is what this is distichiasis, as you see. What is the treatment of distichiasis? Actually, in asymptomatic cases, no treatment is required. But in complicated cases, you should destroy. So destruction of lashes is mandatory. But you apply cryotherapy for this one. But in order to preserve the cosmetic appearance, you should do what? You should do lamellar separation at first in order to separate between the anterior lamella and posterior lamella, and then apply the cryo to the posterior lamella, which will contain the abnormal lashes.
But it will cause meibomian gland dysfunction.
May result in meibomian gland dysfunction, yes.
So it can
But
cause
actually, this is better than, yes, Dr. Isan, this is better than, extremely better than having corneal ulcer or corneal manifestations in relation to abnormal lashes like that. In complicated or symptomatic cases, you have to do this. And also, you will have this one just in one lid. It will be related to the upper lid or the lower lid. So the meibomian glands, which will be in the other lid, will be intact. So you won't suffer from meibomian glands function because of this technique.
Can you do laser epilation?
This will be time consuming, and this will be also not that effective because here you have multiple lashes. It is not just one or two or three. You may have 50, for example. So this will be very hard to track them, okay, one by one using laser. Okay, what is the definition of Madarosis? Madarosis means that you have permanent loss of the eyelashes, and you have local causes which will be related to either chronic ocular inflammation or ocular trauma. Here, inflammation like trachoma, like diphtheria, and so on. And in cases of trauma, like chemical burns and surgery, and so on. Okay, here you have general causes like alopecia. And in alopecia, you have alopecia patchy or alopecia general alopecia or alopecia universalis. In alopecia universalis, all cases of alopecia universalis will have this one, which is called Madarosis. Okay, like this referee. You know this referee, he's called Colina. And he is a very famous referee. I think if you saw the World Cup of 2002, okay.
Yeah, he's Italian.
Yes, he is Italian. Yes, Colina. He has alopecia universalis. He has no hair either in the eyebrow or in the eyelashes or in the scalp or in any part of the body. Has no he has no hair in his skin in general. So he has alopecia universalis. This is a cause of Madarosis also. Myxedema, vitamin A deficiency, which is not that commonly associated with Madarosis, SLE, or systemic lupus erythematosus, and leprosy. Lepromatous leprosy, actually. Treatment is the treatment of the cause together with artificial lashes or implantation of lashes. Well, this is I didn't hear about implantation of lashes for me or for the oculoplastic surgeries that I know. Okay. Here, this is a summary of trichosis regarding the etiology, which is two infections like trachoma and ulcerative blepharitis, two trauma like mechanical or surgical or chemical burns, also two cicatrizing conjunctivitis like Stevens-Johnson syndrome, ocular cicatricial pemphigoid, and diphtheria, which is extremely rare right now. Actually, if you see a case of diphtheria, you should call the WHO. You should inform the WHO about this one. Regarding the pathogenesis, it is scar formation and misdirection or maldirection of lash because of contraction of the hair shaft or the hair follicles. And for the symptoms, you have the 5 P's of the corneal manifestations. For the signs, you have maldirected lashes, you have conjunctival hyperemia, you have corneal vascularization. And for complications, you have chronic conjunctivitis, you have corneal vascularization, ulceration, opacification, together with epithelial hyperplasia and also keratinization of the ocular surface. Treatment of rubbing lashes, temporary with epilation or permanent with electrolysis or argon laser or diathermy or cryo. Treatment of trichosis with entropion is treatment of entropion. Without entropion is transpositional flap or Z-plasty or mucous membrane grafting. For the upper lid, it's called Van Mellingen, and for the lower lid, it's called Webster. I think this is a good summary for this topic of trichosis. These portraits are found in Egypt, in El-Fayoum. They are called, El-Fayoum is a city in Egypt. Okay, these portraits, I think they are 3,000 year before. Okay, so they are very old, and I think these are the first portraits in history. Okay, the art of portrait wasn't found before these ones. And here in this one, you can see that you have a scar. Okay, this one was drawn like that, and you have here a scar, and this scar may be related to cautery because of trichosis. I think this was written actually by ophthalmologists who visited Egypt, and also this is written in a comment in the museum. Actually, this photo is present in a museum in New York, but I can't remember the name of the museum. But this one is not present right now in Egypt. It was found in Egypt, but right now it is not present in Egypt. Okay, this is all what we know about the lashes disorders. Actually, you have trichomegaly, which is increased in lash density and number, and you have poliosis, which is whitening of lashes, but they are related to some diseases which will be mentioned scattered in the curriculum. Positional lid defects and also ptosis. I'll mention them in the next session together with solving some MCQs in relation to lid oculoplasty. Do you have any questions in the part that we have covered right today?
No, thank you.
Not at all. I'll stop the record.
Thank you.